Uh, Thank you, Claire. It's really an honor to be here. I am here as part, I'm in the United Kingdom as part of the ClinGen Decipher meeting that's going to be held later this week at the Hingston Conference Center. So I'm actually not going to talk about variant classification. I was very interested to see you had a variant reclassification meeting yesterday. And I am actually going to talk about some real data. And I actually am going to spend the first half discussing our development of a clinical whole exome test at Baylor College of Medicine and what the results have been in the non-cancer scenario. And then in the second half, really, or the second 60%, focus on our trial of using it in pediatric cancer patients, really to try to compare that the results in the two patient populations are quite different. And so I think it's nice to contrast them. My only disclosure is that Baylor College of Medicine did join with Morocco Holdings in 2015 and developed a more commercial laboratory, the Baylor Morocco Genetics Laboratory, and on their scientific advisory panel. So this is just kind of a timeline of the launch of clinical whole exome sequencing. I assume this audience knows the definition of an exome being the coding regions of the genome, which is what we're going to focus on. And really, one of the things that sparked our development of the clinical whole exome test was the fact that actually in 2011, the National Human Genome Research Institute put out a call for grants, and we had one funded in 2012, which were really designed to say, are we ready to use exome or genome sequencing in the clinic? So not just as a research, but actually in the treatment or care of patients. And so that was the development, that was the development of the Clinical Sequencing Exploratory Research Program called CSER. And that really forced us, because we were one of the labs funded, to say, well, how are we actually going to do this test? And so I see there are many students or young people. I will say one of the nice things about being in academics is you get to do many different phases of your career. You get to do different things. And so really one of the most rewarding things I've gotten to do is now, almost 5 years ago, the head of the medical genetics laboratories at Baylor College of Medicine, Art Beaudet, and Christine Eng, and the head of the Genome Center, Richard Gibbs, got together with a group of medical geneticists, of which I was a group, where kind of the group is down here, and formed what at the time we called the Whole Genome Laboratory. And it was really an attempt to develop a clinical, or in the United States it's referred to as CLIA, accredited and CAP accredited clinical laboratory that did the exome itself as a clinical test. And so we actually developed that test. We first launched it for germline exome diagnosis at the end of 2011. And the grant itself started in 2012. And the test itself became very popular among medical geneticists in the United States, and people started ordering the test. So the test itself is not a research study. Any physician in the United States could order it if the patient's insurance would cover it. And so very early on, and I won't describe this paper in detail, we published in the New England Journal of Medicine a description of the test and the platform itself. It's all publicly downloadable. The analytic program that was used was based on the Human Genome Research Center, Sequencing Center's platform. And Christine Eng and Yaping Yang were the two clinical diagnosticians who signed out the initial reports. So of course, one of the things when you're developing a test, and I know this has been a major topic of discussion in the UK as well, is like, what are you going to report? And so in our exome test, we have what's called the focused germline report, and it actually contains all of these categories. I should say mitochondrial DNA came and went. We did not have it initially. We very early added a mitochondrial DNA component, but over several thousand patients, we literally had only 1 or 2 mitochondrial DNA diagnoses. So it seems at least most physicians in the United States recognize mitochondrial disorders, so we actually no longer offer it, but it was there briefly. But of course, the main focus are what are the variants we find that are related to the patient's phenotype. There's a large phenotype requisition form where you have to describe the patient when you're ordering the test. And for genes related to the phenotype, we report pathogenic variants as well as variants of uncertain significance. The only time we report VUSs are if they are related to the patient's phenotype. We do report other medically actionable or incidental findings, and you're probably aware there's been a lot written about that. And I'm actually not going to talk about it today. I'm happy to take questions about incidental findings. I think it's probably been discussed more than it needs to be. We actually report a very small number of variants in pharmacogenomic genes. These are predominantly variants for which the FDA, the Food and Drug Administration in the United States, has an indication for dosing. I have to say we have not found that to be particularly useful. Most of the doctors ordering exome tests actually are not that interested in the pharmacogenomic portion. And we offer recessive carrier status. And so for the test as a whole, we offer it for genes where population screening is recommended, things like cystic fibrosis and beta globin. For the research study I'll talk about later, we actually report all recessive findings. And we give the parent or the patient the option to opt in or out of this part of the test. Over 90% of parents or adult patients actually request the recessive carrier status. So as I mentioned, the test became very popular, and of course many other labs, both in the UK and in the United States, started ordering such tests. So in 2014, there was an issue of JAMA where it reported both our experience with the first 2,000 non-cancer patients, and I'll describe that in more detail. There was also a paper out of the UCLA laboratory in California with about 800 patients, and Genetics and Medicine published a paper from GeneDx with about 500 patients. So by 2013, 2014, clinical exome sequencing as a diagnostic test had really taken off in the United States. There actually are now a number of different laboratories that offer it. So what did we find? So the first thing we found is that most of the patients that are having exomes ordered are children. And that continues to be true. When we put the data together, it was about 89% of the patients were pediatric. It's not quite that high, but it still is predominantly physicians caring for children who are suspecting a Mendelian disorder who are ordering exome tests. Most of the patients have neurologic phenotypes. So 72% of the patients of the original 2,000, and again, that number has changed a little bit, it's come down a little, have intellectual disability, a seizure disorder, or autism. Plus, they can have additional findings, congenital anomalies. There are a wide variety of other reasons that exome tests get ordered. Each of these are a much smaller component. So patients with unusual skeletal abnormalities, gastrointestinal malformations, cardiovascular, et cetera. It seems like, at least in the United States, physicians are still generally using panels for these diagnoses as opposed to using exomes. And we actually received the referrals from a wide variety of academic and national and international medical centers. And at this point, the laboratory has actually sequenced over 8,000 patients who had their samples sent. The other important thing is to say that early on, unlike most of the other laboratories, and I think unlike what's been done in the UK, is that we actually, and this was really done for cost and efficiency reasons, we only do the exome sequencing on the patient, and then we confirm the findings on the parent. So we're not doing trio exomes. We have switched to that, but these diagnostic rates of about 25% is simply sequencing the proband alone. And what you can see is that depending on the diagnosis of the patient, there are differences in the diagnostic rate. And this is all published data. So for example, specific neurologic features like ataxia had a higher diagnostic rate, although the confidence intervals here overlap. There are some more recent reports that even more specific findings may have even higher diagnostic rates. So there's experience from a couple of groups in the CSER consortium, for example, that patients with congenital eye anomalies have a much higher rate. It's starting to look like patients with specific hematologic disorders may have a diagnosis rate closer to 50%. So I think we really, so I'm just saying that because there are a lot of papers that people talk about the diagnostic rate of exome sequencing. I think it's going to be highly dependent on the phenotype of the patient and is not actually easily translatable from one patient group to another. And I'll talk about the cancer rate, which is actually, frankly, much lower in a few minutes. The other thing, and hopefully this projects okay up there, I don't know what the sun finally came out, but what surprised me is I expected that maybe because I do cancer, that many more of the patients would have their diagnosis based on loss of function mutations. But this is, over 500 patients, so there's a lot of data under this pie chart. About half of the pathogenic or likely pathogenic variants, and those are the only ones I'm showing here, are actually missense alleles. And then the loss of function mutations, of course, make up another big chunk of it. But it's just to say that a lot of the underlying Mendelian disorders here are actually due to missense changes. Perhaps what was more significant is the incredible high rate of de novo mutations. And so, first of all, another thing that turned out to be actually quite interesting is that there were a wide variety of Mendelian mechanisms, quite spread out in the sense that about a third were recessive disorders, about a half were dominant, and then another 13% or so were X-linked. So again, it wasn't a predominance of dominant disorders. However, if you look, and one of the unusual things, and this has held up now over many thousand more, is that the X-linked disorders are equally found in males and females. So again, kind of the opposite of what we're taught as clinical geneticists. And I think the reason it is that to get to an exome, you have to have kind of failed to have a clinical geneticist make your diagnosis. And I think we fail more often in females with X-linked disorders than we do in males. I think there are many X-linked disorders that we forget actually that females can be symptomatic. But one of the striking things, and Jim Lubsky talks about this all the time, is the incredible predominance of de novo mutations in this group of patients. So again, these are patients that are predominantly children with neurodevelopmental disorders. And so you can certainly imagine that they have alleles that impact their fitness or their reproduction. And so of the dominant disorders, about 74% were de novo, another 11% were inherited, and then another 14%. So this 74% could actually be higher where we didn't actually have both parents. So I just want you to keep that in mind. The other thing that was very striking and continues to be true, I think, among all the labs is the impact of newly discovered disease genes. So of those 500 patients, I think Yaping went through the literature and looked at what was the year that that gene was first described to cause that disease for those 500 diagnoses. And what you can see is some of them, of course, are older. And this, I think, this 35 is like everyone before, not 1992, not that that was a special year. But what you can see is that this data analysis was done towards the end of 2013. And you can see that almost 100 of the diagnoses of these 500 patients, that disease gene was not known 2 years prior. And so one of the big advantages of exome sequencing, and I think that continues to be true clinically, is the fact that you don't have to constantly update your panel, right? As a new gene gets discovered, you update your pipeline or you update your search of OMIM or whatever it is, but you don't have to change the physical reagents. And so exomes, again, have been extremely useful in making diagnoses of patients who have newly described disorders. But of course, as I mentioned, most of the patients were pediatric, but at some point we had done enough patients that I encouraged one of my junior colleagues, Jennifer Posey, who's a medical geneticist who recently finished our training program, to say, well, we've actually done a fair number of adults at this point if you look across the entire spectrum. And so we published this paper last year where we really wanted to know, are there differences in what the adult patients who are being referred for clinical exome sequencing actually look like? And first of all, they clinically don't look that different. So again, the idea of doing exome sequencing still seems to be the provenance of medical geneticists and neurologists. And so again, the most common causes, the most common symptoms that the patients had were nervous system or neurologic disorders. However, in the adults, you do see more of patients with unusual musculoskeletal problems, a few patients with eye disorders, and you can see that where I always have to find it, it kind of hides down here, where neoplasm is all the way down here, right? So we've actually looked at who do we see in adult genetics clinic. We see a lot of cancer patients, but cancer patients are still not having exome sequencing done as a diagnostic test. And so again, there seems to be this skewing of who we actually see in clinic versus who actually gets a test ordered. Also, the younger you are, the higher the diagnostic rate. So the patients that were only adults for the last 2 years of their life, so the patients that were 18 to 20, had a similar diagnostic rate to the children. But you can see as they get older, and actually this group in their 20s were the largest cohort of these adults, the diagnostic rate does go down. Now, one of our reviewers was smart enough to say how much of this is because you don't have both parents. And that actually, the reviewer of the paper, that actually turned out to be part of the reason the diagnostic rate goes down, which is that if you have both parents and you can prove that a mutation is de novo, that increases your diagnostic rate. And as you get older, the likelihood you're going to have parental samples goes down. But certainly the availability of parental samples clearly does not explain all of the fact that as you get older, it's just much more likely that either acquired or somatic mutation or environmental causes are causing your underlying medical problem than when you're younger. Also, similarly, there were certain, and I won't go through this in detail, there were certain diagnostic types that had a higher diagnostic rate, in particularly abnormalities of the neck and the musculoskeletal patients, as well as abnormalities of the nervous system. And again, as I'll show with our own data, the patients who had cancer had a lower diagnostic rate than some of the other diagnostic groups. Of course, one of the most frustrating things is to do an exome test and not make a diagnosis. So there's been a huge effort to try to improve the diagnostic rate and to reevaluate the data over time. And Pengfei Liu is one of the junior faculty at Baylor College of Medicine, really drove some of this early work. And so what he did was looked at the 75% or so that were undiagnosed originally, and then looked over time, how many patients were we able to convert from a negative result to actually a positive result and really give an amended report. And it's a small number, but this is of several thousand patients. It was about 4% of the patients we actually over time were able to diagnose. And again, the overwhelming reason that we were able to diagnose them was because there was a new disease gene discovered. There were some other things. We got an additional parental sample, or we discovered a copy number variation that had been missed the first time around, or things like that. But again, most of the new diagnoses are, again, because researchers, people like you and others in the field, are learning about new disease genes and publishing them. Also, we have an alliance with the Center for Mendelian Genomics at Baylor and Johns Hopkins. We work very closely with them also to convert. And one thing I should say about that is we often think that the new disease genes are going to be rare. That is actually not always the case. And so these are 5 genes for which we did not know about this gene as a disease gene at the time the patient's exome was initially ordered. But then either through work with the Center for Mendelian Genomics or through publications, we learned about the gene. And you can see that the number of patients that are solved once that gene was published actually can be quite a few. So this is just by searching our database of unsolved cases. Each of these genes, there were more than 5 patients. And I think for Tango 2, it was something like 16 patients who were undiagnosed until we knew about that disease gene and then clearly had a pathogenic mutation. So it's just to say that we think that all the common ones have been found, but that's really not the case, particularly when you're talking about neurodevelopmental disorders. There are probably a lot of still common disease genes out there to be discovered that once they're identified, can explain actually a number of undiagnosed patients. The final thing, and this was presented in the American Journal of Human Genetics, and we've now done some further analyses, is the question, and one of the early surprises was how often a patient had 2 different Mendelian diagnoses. So now these are not just 2 different Mendelian disorders, but these are actually 2 different Mendelian disorders for which the patient had some phenotypic manifestation. And of course, I think this group is all familiar with, we often talk about modifier alleles. Modifier alleles are really something different. That's saying you have a Mendelian disorder, and now you have another genetic variant that actually somehow affects the phenotype. There are also triallelic disorders. Again, they're these disorders that look like they should be classically recessive, but in fact, you have to have not only both alleles from one gene, but a third gene. But what we're talking about here are actually two often unrelated Mendelian disorders. So an example here where both parents are the carriers of a recessive mutation in one gene, and then the child also has a de novo mutation in a dominant disorder. And so this child's going to have manifestations of both the recessive disorder as well as this de novo dominant disorder. And overall, and this is now looking at about 1,400 patients with a diagnostic report, it's almost 6% of the time there's actually two different Mendelian diagnoses made. We actually had 2 patients who had 4 or more Mendelian diagnoses on theirs and 6 who had 3. But of course, the majority of patients who had 2, 74 of this group, had 2 different Mendelian diagnoses. Again, de novo mutations play a major role. So here, these are patients that had 2 different de novo mutations in 2 different disease alleles. These are patients who had at least 1. And then there are some patients who inherit 2 different dominant alleles from their family. Similarly, there are a lot of patients that have a recessive disorder from their parents and then have a de novo dominant disorder, et cetera. And so you can kind of see all different combinations of Mendelian inheritance, as well as all different combinations of inheritance when you look at these patients with multiple phenotypes. So then finally, the question began, can we do this fast enough to actually be used in a variety of clinical settings where currently it just wasn't possible. So the original exome test was set up for the results to come back in about 14 weeks. And we're pretty good about making that 12 to 14 week cutoff. I didn't show the data, but we also now do it as a trio if both parents are available, and that's actually reported out a little more faster because you don't have to check the parental inheritance. But the question was, could we really keep the quality of the data at the same time as doing it faster? So I first just wanted to highlight Donna Mosley, and this was my slide with her picture, because she is actually the person who managed both the Genome Center operations and the operations of the Exome Lab. So she's actually the person who got the tubes into the right place, the robots to work, the machines to run. And so for those of you who are in labs, you know that is not a small feat. But she's also very proud of this graph. This shows the coverage of the clinical exome over now, this is at 7,500 samples. And we set a cutoff that we wanted greater than 95% at 20x coverage. And you can see that we've kept to that. And if anything, the coverage is actually improved. We're now normally at 98% over 20x. The other thing all these boxes highlight is all of the improvements to the pipeline that have been made over time. And so one of the things that's talked about a lot is which genes do you know, which clinically important genes are you not covering well? And so Donna has published a number of papers really looking at trying to improve the coverage. And this particular jump up was partly the improvement in the coverage, as well as actually improving the coverage of exons that were otherwise not covered well. And so there's, and I would say that's one thing that continues to be different about the different pipelines. There's certainly difficult to sequence regions that we all probably don't cover well, but clearly the different exome pipelines have different genes or exons they don't cover. So there's certainly going to be patients who don't get diagnosed with one pipeline and do with another, depending on if you happen to have a disease-associated mutation in one of those exons. But what Donna was kind of charged with was how quickly could we do it if we wanted to actually do it routinely. I don't mean just do it once, but if we wanted to be able to do it clinically, but do it for children who were ill. And so she put together a team to design what we call the critical trio exome. And you can see these were all the different steps from the actual library to the capture to the sequencing. And then, of course, the clinical team doing the analysis and then the filtering and prioritization. And they got this down from about 20 days to less than 3 days. And with that, and with the clinical team and having a trio exome, so you have both parents, so you don't have to go back and check the phase, we launched what we refer to as our critical trio whole exome sequencing. And this is primarily being used for patients where you really have to assist management rapidly. The test itself is signed out. The report comes back to the physician within 3 weeks, and in most patients, actually, it's coming back in about 2 weeks. And it is more expensive, I'll just be honest about that, but it's indicated for cases where you need that information to try to guide patient management. And so this is just some of the early data when they did their first 40. The diagnostic rate was actually higher if you include both possibly solved, and their definition of possibly solved is really almost really likely solved, and solved. But of course, there's still a number of patients where we still get a negative test. But I think, first of all, these are quite ill patients, so the likelihood they have a Mendelian disease may be higher, and we're doing trio analysis, and I think both of those things combine. But I just wanted to give one example, since I do more cancer work, to just show you how the surprises that come out of exome sequencing, and I have to say, clinically, that's been one of the kind of most interesting thing about the last 4 years, or is you just get results you don't expect, even if you're a fairly experienced clinician. So this was not a child I saw, but this was a baby in the intensive care unit who was born with intrauterine growth retardation. I apologize for the acronyms here. It was a 4-day-old male. He was admitted to the intensive care unit with respiratory distress. He had pale skin and petechiae, and he had bruising on his chest and back. And so his initial lab workup revealed pancytopenia. And his critical trio was sent off, and the result came back in 10 days. And this patient actually had Fanconi anemia type A, so Fanc A, one of the most common forms of Fanconi anemia. Now, you might say, why is that surprising if you're not actually a hematologist? Because it's got the name anemia in it. And the reason that's surprising is, in fact, the average age of bone marrow failure presentation in Fanconi anemia type A is 6 years old. And if you look at the literature, there are actually a couple of other reported cases. I frankly wasn't aware of this, but there were a couple of other reported cases of congenital pancytopenia in patients with Fanconi anemia. But it's an extremely rare presentation of this disorder. And this, of course, had a huge impact on the patient's care. They were about ready to do a bone marrow biopsy, which they didn't need to do because they had it. But much more importantly, they knew that this child now needed to have plans for bone marrow transplantation. You have to monitor the patients for other abnormalities seen in Fanconi anemia, like renal anomalies, and they can have congenital heart disease. The patient was actually discharged from the unit, was transfused, discharged from the unit, and is now being followed in the hematology clinic with a plan for bone marrow transplantation. But I think these are the kind of examples that you could get a lot of highly experienced clinicians in the room. This would not have been, this was nowhere near the first, second, or third diagnosis on their list. And I believe this trio would have come back sooner than we could get diapoxy butane breakage studies back, at least in the US. Okay, so to summarize the non-cancer whole exome sequencing experience, the majority of patients that have been referred have neurodevelopmental phenotypes, although there is a growing interest in using whole exome sequencing in different clinical scenarios. The diagnostic rate is approximately 25%, which clearly is increased further by doing parent-child trios. And many people would argue that's probably closer to 30%, and certainly other groups have reported that. There is a balance of autosomal dominant, autosomal recessive, and X-linked underlying diagnoses. De novo mutations are a major feature of these Mendelian diagnoses, and about 5% or 5 or 6% of patients with a diagnosis actually have 2 or more Mendelian disorders. And obviously, as I mentioned, one of the goals is for the non-diagnostic cases to be further studied and solved, and we're using a variety of research mechanisms to do that. So with that, I'd like to switch and talk about our cancer study. And as I mentioned, this was part of the Clinical Sequencing Exploratory Research Consortium. This is funded by the National Human National Human Genome Research Institute and the National Cancer Institute in the United States. We're here, there are 9 centers that each got a clinical trial, grant to do a clinical trial of sequencing, and there are additional sites that are doing a variety of studies on kind of the behavioral and psychosocial aspects of this. So we called our study, it was originally called Basic Cube. I'm a nerd, I went to MIT, but no one knows what cubed means in the United States, so we switched to Basic 3. And it's Baylor College of Medicine Advancing Sequencing into Childhood Cancer Care, that's the 3 C's. Will Parsons, who's a pediatric oncologist, is my colleague, and we're co-principal investigators of this study. And this kind of sums up the study, which is that we propose to do whole exome sequencing of newly diagnosed solid tumor patients. We did not do leukemia and lymphoma, and I can explain why if people have interest. And these are newly diagnosed and completely unselected. So that will be very important to what I say about the germline. So they were totally unselected based on their diagnosis. If they had a CNS tumor, it could be any grade. If they had a non-central nervous system tumor, then it had to be a malignancy. So if they had a lipoma or something like that, they didn't get in the study. But otherwise, we approached everyone in our clinic who spoke English or Spanish. We have a very diverse patient population, but it's predominantly, the predominant group is either non-Hispanic white or Hispanic white. We have about 10% African Americans. We got a blood sample and a frozen tumor sample at the time of their initial surgery or biopsy that was sent to the laboratory I just described for clinical sequencing. But in this case, they did a tumor normal pair per lane. So it's actually sequenced a little bit deeper. It's about 250-fold average coverage. And the patients actually get a germline exome report, like I just described, the focus report, and they get a tumor report that I'll talk about a little bit at the very end. These reports go back into the electronic medical record. So these are ordered like you would order any test. They go back in the electronic medical record. Dr. Parsons and I meet with the oncologist to review the results, and the oncologist and a genetic counselor meet to disclose the results to the family. So they might never see a medical geneticist in the study. And then we're following the patients for 2 years. And we did just enroll our 280th patient over 4 years, so we have completed enrollment. And the goal was to really look at to integrate the information, both germline and tumor, and to really look at what was the impact on the patient and on the oncologist. I won't talk about it today, but the oncologists, and there are now 20 of them, are actually subjects in the study. They've been interviewed by neither me nor Dr. Parsons, Will Parsons. They've been interviewed at the beginning of the study, after they do it for a while, and at the end. And the parents have also been interviewed. A subset of the parents have been interviewed. So the first question was, would parents be willing to even enroll? And we published this now quite a while ago. In fact, the parents were. And originally it was 83% overall. Now that we finished enrollment, it dropped a little bit. It's about 70 or 72% was the final number. And interestingly, parents of patients with cancer have a different set of concerns. So, when we started this, everyone said, well, they're going to be concerned about privacy and genetic anxiety, like they don't want to know the results. There are about 5%, and that's still about true. There's about 5 or 7% of the parents that are concerned about those issues. The main reason the parents decline is they're just overwhelmed. Their child was just diagnosed with cancer. They just can't they've often already entered a research protocol for the treatment trial. They often just don't want to be involved in another research study. But overwhelmingly, they were interested in participating. The other thing we were very worried about is we are a very diverse clinic. None of the investigators speak Spanish. We went to great lengths to translate everything. The hospital provided hospital translators for free for all of the consent and disclosure and everything else. And we're actually very pleased, and we published this, but I've updated it now. This was when we were up to almost 240 patients. There was really no difference in willingness to participate in the study between Hispanic and non-Hispanic individuals, and also individuals who actually used the translator. Again, it was approximately the same proportion. So there were no statistically significant differences between race or ethnicity and their willingness to participate. The other thing that's very diverse about pediatric cancer is the cancers themselves. So unlike adult malignancies where you have breast cancer and colon cancer and lung cancer and prostate probably being a big part of the pie, pediatric cancers they're just a large number of individually rare diagnoses. So these are actually the pie charts when we were up to 121 patients. I don't think Will has updated it since, but you can see there are some major players like neuroblastoma and Wilms tumor and low-grade glioma and medulloblastoma, but there are very large number of individually rare cancers that make up this unselected group. The reason I highlight this is that many of you are probably aware that in the New England Journal of Medicine, St. Jude Children's Hospital published their results with about 1,200 patients, and they came to actually the same proportion of germline findings, which I'll talk about in a minute, but their patient population was extremely skewed towards P53 mutations, which you'll see was not what we found. But that's because they have a very high proportion of patients with a couple of rare subtypes who have P53. I'm sorry, I normally put that slide in, but I realized it was left out of here. So in this case, it's the same germline report plus the tumor report, which I'll talk about in a minute, where we actually report all of the somatic mutations. But for the germline, I'm only going to talk about what did we find relative to their cancer or any other medical problem that the child had. And so much of this work for the first 150 patients was reported back in January, and I'll provide you some of the updated numbers as well. So this is the data that was in the paper. Of the first 150 patients, 10% of them had a diagnostic finding. The majority were dominant disorders with only a single autosomal recessive disorder made. And in this case, we found one X-linked disorder, which was related to an undiagnosed renal disease that the patient had. I just looked at the numbers. We have reports in for 255 subjects, and the cancer diagnosis is really almost spot on at 10%. It's 9.8% have a diagnostic finding. Again, they're almost entirely autosomal dominant disorders. We've only made one other recessive diagnosis. That was a patient who had a known metabolic disorder where we found the mutations that caused it. But among the cancer susceptibility, it's actually extremely rare in an unselected population to actually make a diagnosis of a recessive cancer disorder. And this is similar to what St. Jude reported as well. There are a large number of patients who carry a single recessive pathogenic mutation. So we have a large number of Fanconi anemia mutation carriers in the population. But when we compare it to our non-cancer population, the carrier rate for these cancer susceptibility syndromes is actually very similar to what we see in the 2,000 non-cancer patients that we reported. So I just say that if you're doing exome or genome sequencing, you will find a lot of single carriers of Fanconi anemia and Shwachman-Diamond syndrome and even Rothman-Thompson syndrome, one of my old favorites. It's very hard to say whether any of those actually relate to the cancer diagnosis. We have looked at loss of heterozygosity. We really rarely see it in the gene, in the tumor. We did report in our previous paper there was one patient who had a mutation in DIS3L2. How many people know what disorder that is? I didn't at the time, so that's why I was just wondering. So that's Perelman syndrome, and that's actually an overgrowth disorder with Wilms tumor. And that patient's Wilms tumor actually had lots. That was the only patient who had the right tumor with at least the right recessive syndrome, and was the only one where we saw loss of heterozygosity. So it's very hard to say for these single pathogenic mutation carriers and for recessive disorders whether that's just coincidence or whether that really in some way there's some low cancer rate that even though they don't have the rest of the syndrome that we didn't know. The other thing, however, is that when we actually looked at what were the mutations of these in these 13 patients, 8 of them were in a gene known to be associated with that tumor. So VHL and pheochromocytoma, or WT1 and Wilms tumor. There were another 5 where it's clearly a pathogenic mutation in a cancer gene, but that gene had not previously been associated with that cancer. The most notable ones were BRCA1 and BRCA2. We actually had a total of 3 at the time we wrote the paper. We still actually have a total of 3. And I think statistically it's very close to what we would expect for the carrier frequency. And the 3 patients at the time each had a different cancer type. So we actually don't think our data is that suggestive that BRCA1 and 2 may have a childhood cancer predisposition. St. Jude also found BRCA1 and 2 mutations. I think it's going to take very, very careful epidemiology to figure out if there's really a childhood cancer risk associated with BRCA1 and BRCA2. But we found them. And then we did, as I said, we did make one recessive disorder. This is a gene that had only recently been described as causing a very severe liver phenotype. The patient did have progressive cholestatic liver disease and had developed hepatocellular carcinoma. We actually identified one other patient unrelated to the study with that combination. And there's now, I think, been a third. So clearly, this particular cholestatic liver disease in young children seems to predispose to HCC. So in terms of the inheritance pattern, it looked very different from what we saw in the non-cancer population. So as I mentioned, it was almost all dominant disorders. There were almost no recessive or X-linked disorders. We also had parental DNA for 13 of these 15 patients, and in 11 of the 13 was inherited. We actually now know for the 14th that it was inherited as well, because there's a cousin with the same mutation. And the family history, if you actually had the family history was often missing in the medical record, was often consistent with these diagnoses. We did have a patient with somatic mosaic W21 mutation. We've subsequently had another de novo W21 mutation, and we had one de novo KRAS. But again, the pattern is very different than what we saw in the non-cancer whole exome sequencing results. I would say the parents are very interested in these results. All of the siblings of these childhood cancer patients who were at risk for inheriting the allele have all undergone testing, and that's not done as part of the study, that's clinical testing. And they are now undergoing surveillance as indicated. We do report variants of uncertain significance in cancer genes in these reports. There's a median of 3 VUSs per subject. And the lab does look, almost none of these are de novo. I think there was maybe 1 de novo. And again, this is what, I know there's a lot of interest in VUSs. This is what at 215 patients, and now it still looks this way. There's a median of 3. There's really no significant difference in the number of VUSs based on the tumor type, the age of the patient, the gender, or the ethnicity. We thought that the Hispanic patients would have more variants of uncertain significance. They really don't. There's really no, the 2 curves overlap perfectly. Of course, as should be expected, the African Americans in the population did have an increased risk of variants of uncertain significance, but that was the only thing that was predictive of VUSs. Okay, so many of you, or some of you in the audience, are clinicians. So the question is, how often can we predict what we were going to find? Because that's clearly the key issue. If we could predict it all the time, then you don't need an exome. So what we've done in this study is, first of all, we looked, now that we have the results, could we actually just, based on the patient characteristics, see if any group has a higher diagnostic rate than others. And statistically, there was no difference based on age, the location, whether it was CNS versus non-CNS, or the tumor type. And this we only did for the most common types, so like Wilms tumor, neuroblastoma, tumors where we had at least 10 patients. The diagnostic rate was the same. Now, the age thing might surprise many of you. If you actually look at the numbers, I'm sorry, I should have made a slide of it. The youngest patients had a slightly higher diagnostic rate, but it was statistically not significantly different. And even the oldest of the kids still had a diagnostic rate of like 7% instead of 10%. So just stratifying on age, it would help you a little bit, but clearly it's not nearly predictive enough, which many of us do clinically. So many of us will order p53 testing for rhabdomyosarcoma patients under the age of 3, but not over. The data makes it clear that those kind of rules enrich for positives, but you miss many negatives. The only group that had a higher diagnostic rate was this other group, and that included things like rare subtypes, so pheochromocytoma, pulmonary pleuroblastoma, and a few other rare subtypes. That had a diagnostic rate of about 30% instead of the 10% for everybody else. But more importantly, for each of these patients, at the time they entered the study, either myself, and I've been in cancer genetics 23 years, or my genetic counselors who worked with me for quite a while, we looked at each patient. We said, based on everything in the electronic medical record, so we were free to look at everything, and the family history, if the parents filled out the family history questionnaire, or the family history of the oncologist, and the tumor type, and the age. If we were seeing the patient in cancer genetics clinic, would we order genetic testing? And we were very liberal. So if we thought we would even consider it, we said yes. And we had to say what gene we would have tested for, or what test we would have done. And so we did that at entry for all 280 patients. So in looking at the patients, so this is when we were at 255, so we had 25, because I said the diagnostic rate was 9.8%. We actually only predicted the gene 13 of the 25 times. That's really not a very good rate. And so if you're going to miss half of the patients that have a diagnosis, I think it means that our current clinical practice, and to be frank, most childhood cancer patients in the United States do not see a geneticist who specializes in cancer genetics. So this was like the optimal scenario. Clearly, we got a lot of unexpected results. So in the last few minutes, I'll just show you a few of those and then just talk briefly. So this is the first one. This is a newly described tumor suppressor gene, SMARCA4. It's part of the chromatin remodeling complex. The patient had a Frameshift mutation, but the patient has a neuroblastoma. Now, there are only a few papers describing germline SMARCA4 mutations in cancer. There are many more describing it in coffin serous. And what it's described in is rhabdoid tumors. This patient does not have a rhabdoid tumor. The pathology was reevaluated. But what's shown here is the germline calls, and you can see about half of the germline calls have the mutation, and there's complete loss of heterozygosity in the tumor. So whether this is a newly described tumor suppressor gene and we're just learning what types of pediatric cancers you can get from this, or whether this is a complete coincidence, we don't know yet. But this is, of course, the type of thing we would not have predicted to test for. The second is, of course, patients can be mosaic for mutations, and we often rely on family history or other features of the disorder that you won't see if a patient's mosaic. And so this is just an example of mosaicism and in fact, the fact that it, of course, can be passed down. So this is a patient who was a 9-month-old male with stage 3 Wilms tumor. There was no family history of cancer. The child had no congenital anomalies. It was clearly unilateral disease, and so we did not recommend genetic testing because we don't do genetic testing on all Wilms tumor patients. But what you can see kind of beautifully here in the pileup, and I'm sorry, this time the germline's on the bottom, is the patient actually has 3 different alleles. They have a normal allele, they have an allele with a polymorphism in it, and then they have another allele with a frameshift. And so in this case, about 30% of the alleles, or about 30% of the cells, appear to have this frameshift mutation that clearly is not in all of the cells in the body. Of course, what you can see is in the tumor, it's the cells with the WT1 frameshift that are what make up the tumor, and there's then complete loss of heterozygosity. So this has significant impact for the patient. Certainly, it puts their risk of contralateral Wilms tumor to be much higher, and as we were just talking about before the coffee beforehand, it also means the child has a much, much higher rate of end-stage renal failure and really needs much more careful monitoring of renal function. And again, this was not something we would have predicted. And then finally, the other point I always try to make to my oncology colleagues, although geneticists probably don't need to be told that, is that a diagnosis can be important even if you don't help the patient. So this was a 14-year-old with a glioblastoma. Interestingly, the medical record says nothing about a family history of cancer. At the time the mother consented to participate in the study, she said, oh, well, you know, I have this significant family history, and I didn't draw out the whole pedigree. That's very typical of Lynch syndrome. So this is a patient where we said, oh, well, if we knew that family history, we would test for the mismatch repair genes. And in fact, the child had a frameshift mutation in MSH2. Now, this is one of the first children in the study. She has subsequently died of her disease. And at the time, it didn't make a clinical difference. Now, today, it might have. So if she were diagnosed now because of what we know about checkpoint inhibitors, the fact that she has an MSH2 mutation might have caused her to be treated, at least on a trial, differently. But clearly, making the diagnosis of Lynch syndrome is extremely important for the family. The mother had never been told she needed colonoscopy, even though she was in her 40s at the time. And clearly, we've now identified a number of MSH2 positive individuals in the family. So I think in this case, the germline mutation was helpful for the family, even though it was not helpful for her tragic diagnosis. And then finally, of course, I'm sorry, there's a lot of text here. You can find mutations in expected genes that are still clinically useful. This was a patient with a pheochromocytoma who actually was found to have a VHL mutation, this R167W. The patient's now undergoing VHL surveillance, but we also identified that the sister also carried this. And actually, at her first, she was perfectly healthy when she came in for her first screening MRI, but she was also found to already have a very low level of an increase of plasma and metanephrines, and actually was diagnosed by MRI and the metanephrines with a pheochromocytoma. So kind of an early diagnosis as opposed to her brother, who had had severe hypertension and headaches before he was diagnosed. Okay, so to contrast the two groups, if you look at the diagnostic rate, our study found 10%, the St. Jude study found 10%, and the University of Michigan all found that 10% of unselected, each unselected different ways, but unselected for family history, of pediatric cancer patients have a germline cancer susceptibility mutation. Of course, in the neurodevelopmental disorders, it's probably closer to 25 or 30%. Autosomal dominant disorders clearly predominate in the childhood cancer population. In the neurodevelopmental, it was much more of a mixture of dominant, recessive, and X-linked. The numbers are still very small, but clearly the majority of the mutations appear to be inherited, whereas 70% of the patients in the other group are de novo, and you can see more than one de novo mutation. And the main impact of the germline cancer findings are to impact screening and surveillance. The tumor, as I showed you, if you have the tumor, it's often very helpful in helping to define the germline findings. Whereas in the neurodevelopmental group, the results are often used for diagnosis and recurrence risk. They're less likely to actually affect treatment, although there's certainly examples where they do. So then just a couple of minutes, I'm just going to mention very briefly the somatic results, because that's what my colleagues worked on. We do actually report all of the somatic mutations, and we divided them into 4 categories, with the first category being a known mutation in a known cancer gene in the right tumor. And category 2 is a known mutation in a known cancer gene, but perhaps not identified in that cancer before. And category 3 is all other cancer genes. And so the main point to make is, again, like the germline findings, it's a very diverse set of genes. Beta-catenin is the major player, or I shouldn't say major player, it's still 8% of the patients, but the most common one. And I forgot to say, in the germline, we actually only found 2 p53 mutations, and we're now up to 250 patients, and we've only found 3. So again, we think of p53 being the predominant gene, but both somatically and germline, it's not necessarily any more frequent than many of these other genes. But there are a very large number of genes with mutations that are only found in 1 or 2 patients, and often they were never reported in a pediatric cancer before. So again, if you try to focus on just known genes or known somatic mutations, you miss many of them. And then just about a quarter of the patients have mutations that are either in category 1 or category 2, and therefore might be clinically relevant in the care of the child. So to just summarize, and I think I'll skip my last couple steps to leave time for questions, the last couple slides. The overall result is that if you combine germline and somatic mutations, and so Will Parsons put together this chart, and I have to give him credit, each of these slices is a patient. The inner rung are just those common pharmacogenetic alleles, so not surprisingly, almost everyone carries one. The next rung are recessive carrier status. So again, these two are probably important reproductively or for other drugs, but not related to the cancer. These are the actionable incidental findings. It's a few percent of the patients. But these are the patients who have either a germline, either a tumor finding in class 1 or class 2, category 1 or category 2, or a major cancer susceptibility mutation. And so if you combine just those two classes, it's about 40% of the pediatric cancer patients have an important finding either in their tumor or in their germline. And I think I was just going to give one tumor-specific example, but it's published, so I think I'll end early, related to clear cell sarcoma of the kidney, where we were able to find an internal tandem duplication. But with that, I just want to really acknowledge again that this has been really a large team. And these are some of the major players, both from the laboratory and clinically, that have worked on this project. This is really the much bigger team that's just worked on the cancer part. I could have an equally dense slide of all of the people that really work on getting the clinical exome test itself to work. And with that, I'll take questions.